Thank you, everyone. As Carolyn said, my name is Matthew Ricketson. I'm a Professor of Communication here at Deakin, and I'd like to begin the session also by acknowledging the traditional owners of the land on which we're meeting today, the Wurundjeri people, and to pay my respects to elders past, present and emerging, and to acknowledge any Aboriginal and Torres Strait Islander people who are in the room today with us. So we're going to kind of switch the focus now from both the architects of the Medicare system and the Medicare program as we know it and have experienced it over the last 40 years, and the people at the coalface and as general practitioners and so on, to consumers, if you like, and to all of us really in the room and representatives of all of us, because of course, as is already apparent from things that have been said today, this is a system that's not only been in place for 4 decades, it's something which all Australians experience, for better and for worse, and to an extent have an investment in it. And as was discussed by my Deakin colleague, Professor Catherine Bennett, the results of the survey. So we have 3 speakers in this session, and the way we'll go is for each of the speakers to provide a presentation. Then we'll have a little bit of a panel discussion and then throw it open to questions from you. And the first speaker, I'll just go through them very briefly and then bring up our first speaker. It's Nicole Bartholomeusz, who's the Chief Executive of Cohealth. And Cohealth is a not-for-profit community health organisation providing services in Melbourne's CBD, northern and western suburbs. And she is going to be our first speaker. The second speaker is Dr. Elizabeth Deveny, who's the Chief Executive Officer of the Consumer Health Forum of Australia, whose purpose is reasonably self-explanatory in its title. And the third is Nguyen, who is the Chair and Spokesperson of the National Oral Health Alliance. And they are an alliance that supports action by governments to improve the oral health of all Australians. Tan is also a colleague here at Deakin as a research fellow here at the university. So without further ado, because it is already 12, I'll invite Nicole to come up and speak to you. Thank you.
Thank you. Really great to be here this afternoon. Thank you so much for the invitation. Can I also start by acknowledging Aboriginal and Torres Strait Islander people as the first people and traditional owners and custodians of the land and waterways on which we live, and pay my respects to elders past and present and Aboriginal and Torres Strait Islander people here with us today. I'd also like to acknowledge Dr. Rowena Ryan, who is a general practitioner at Cohealth and a colleague. So good to see you here today, Rowena. So it's great to be here to celebrate the 40th anniversary of Medicare and to reflect on and celebrate a health system that rivals many others around the world. Now, let me just check how I do this. Maybe I'll use the keyboard. As the CEO of Cohealth, a Victorian and Tasmanian-based community health organisation, we've just celebrated the 50th anniversary of community health, a system that was established around the same time as the Whitlam government introduced the first iteration of Medicare. I can't talk about the grassroots of Medicare without first talking about the community health model and acknowledging our history and the work of Dr. Moscas, a doctor and a federal government politician, a man with a vision and a passion for access to healthcare. In the 1960s, Dr. Cass played an integral role in reforming Australia's health system and was involved in the development of universal health insurance in Australia, the system that we all celebrate today as Medicare. Dr. Cass was also instrumental in the foundational years of Cohealth in Melbourne's West during this time. Dr. Cass was the first medical director of the Trade Union Clinic and Research Centre, established in 1964 by the Australian Meat Industry Employees Union. It provided free patient-centred holistic healthcare and helped pioneer a new model of community health. The Paisley Street Clinic, as we fondly refer to it, in Footscray, went on to become Western Region Health Centre, and then through an amalgamation in 2014 became part of Cohealth, one of Australia's largest community health organisations. As it did in the 1960s under the visionary leadership of Dr. Moss Cass, the clinic continues to provide free, holistic, multidisciplinary, preventative and treatment services. And as Cohealth, we continue to advocate for accessible healthcare for all. Dr. Moss Cass became the Federal Minister for Maribyrnong from 1969 to 83, was the Environment Minister in the Whitlam government when the first iteration of Medicare and the Community Health Program reformed Australia's health system. He was visionary in bringing health services to the people. In the 1960s, Dr. Cass envisaged a reformed health system and was involved in the development of the universal health insurance system in Australia, which we now know as Medicare. He was a staunch advocate for providing healthcare in the community, seeing healthcare as a right, not as a commodity. And for me, this still rings true today on the 40th anniversary of Medicare. In 1984, Prime Minister Hawke said that this was a historic initiative. All Australians now have a new, simpler and fairer health insurance system. As a community health organisation, in many ways, this summarises what we strive to achieve every day: easy and fair access to healthcare for people that might otherwise struggle to access the care and support that they need. Last year, we celebrated 50 years of community health. This has provided us with an opportunity to reflect on our health system and the unique role that we play in the broader public health system here in Victoria. For those who aren't familiar with community health, the Whitlam government launched the National Community Health Program in 1973 to shift the emphasis of healthcare from treatment to prevention and to provide an alternative to general practice and to reduce the community's dependence on hospitals. Who would have thought? In 1973. Today, Victoria is the only jurisdiction that maintains community health, a community health program as part of its public health system, with over 75 community health services that continue to support the health and wellbeing of Victorians. Like Medicare, community health was designed to provide adequate health care to all, regardless of their financial means. As one of these 75 services, Cohealth has over 30 sites across Victoria and Tasmania, providing a comprehensive range of services. Beyond our primary care general practitioners, we also provide a range of prevention, early intervention and treatment services across nursing, allied health, pharmacy, public oral health services, primary and residential mental health services, alcohol and drug services, including outreach. We have specialist primary healthcare teams providing trauma-informed, culturally appropriate care to our most vulnerable communities. We provide homelessness outreach and drop-in services, and as of today became the provider of primary healthcare in Victoria's youth justice system. To the community, our aim is for these services to be seamless, connected and trusted. To achieve this for our clients, Cohealth operates as a funding aggregator, orchestrating a multitude of funding sources behind the scenes to create a seamless experience for our clients. Medicare plays a crucial role in making this possible, contributing about 25% of our overall funding, so relatively small in the scheme of things. While this might be less than what you would have thought, Cohealth could not provide the care that we do without Medicare. Equally, we can't do everything that we do just with Medicare. We bulk bill 90% of our medical clients and rely on incentive payments to support some of our allied health services. However, it's essential to recognise that Cohealth relies, and community health more broadly in Victoria, relies on a diverse range of funding sources, both from state and federal governments, to provide the complex and comprehensive services that we do. In addition to Medicare, we rely on core community health program funding through the Victorian government and many, many different program-based funding streams. About 85 funding streams in total to deliver 45 service offerings. You can imagine it's a tin of spaghetti in the back end. Cohealth's role is in many ways that of a funding aggregator with different streams of funding provided, coming together to provide the range of services that our community needs. Rising out-of-pocket costs for primary care affecting more and more people in the community, and we aim to be as open and transparent with people so they can come to us knowing that they won't be turned away. To achieve our seamless multidisciplinary care, we prioritise building strong relationships, a culture of collaboration, and optimising the care team, both among our staff and the clients and communities that we work with. I was recently speaking with one of our GPs and a podiatrist at our Collingwood Health Centre. In their day-to-day work life, the healthcare team sees a range of clients with health and social care needs. For example, an older client who might have had a fall, but also worried about their Centrelink payments or needing legal advice. The treating clinician will talk to the client, understand their issues, walk them over, introduce them to the podiatrist, make the follow-up appointment. They also introduce the client to one of our care connectors to help them with the paperwork and to organise for them to come in and get free confidential legal advice. This isn't just a good experience for the clients, it's a rewarding way to work for our staff. Our staff work at the top of their scope of practice and the care is wrapped around the client with the ultimate goal of maintaining health and independence in community. Staff tell me time and again that they choose to work at Cohealth because they can't practice their skills in the way they do at Cohealth anywhere else. It's what attracts people to work for us and has our doctors telling us how happy they are to be salaried, not reliant on billable hours they experience in private clinics, not having to think about the business, but being able to solely focus on what they train to do to provide great medicine every day to every person. There's been a lot of discussion about Medicare over the past 2 years. The Strengthening Medicare Task Force looked at Medicare and considered what needed to change to ensure that Medicare continues to be the bedrock of a strong and equitable health system. From the outcomes of the task force, the government announced several measures, including the tripling of the bulk billing rate, which I can tell you had our staff literally cheering and crying in the hallways when that budget was announced. To Cohealth, this is what we do every day and we know it makes a difference. But it isn't easy. As a not-for-profit registered charity, annually, Cohealth invests around $3 million a year to keep our salaried GPs and bulk billing medical clinics open. It's not sustainable, but my message today is that if we want a healthy care system, then we need to shift. We need to work together differently and we need to focus on creating healthcare policy and funding models that supports the delivery of primary care in an age of chronic illness. Community health in Victoria is evidence that it exists and it works. I'm looking forward to the conversation this afternoon and ongoing discussion outside of this room about how we improve our healthcare system to continue to support health and wellbeing for our communities, underpinned by a robust and contemporary universal healthcare system. Thank you.
Conscious it's a long time since morning tea, so try and keep you awake, see how I go. So I just also would like to thank Deakin for the opportunity to come here today. It's been a really great morning so far, really enjoying the conversation. I'd also like to, as I'm here in Naarm, just acknowledge the traditional owners of the lands on which we're meeting and also pay my respects to elders past and present, and also acknowledge any Aboriginal and Torres Strait Islander people who are here with us today. I've got a couple of other quick acknowledgements I'd like to make. The first, my board chair is here, and it's a career limiting move not to acknowledge your board chair, as you know. But more importantly, Tony Lawson, our board chair, has been involved for over a decade, tirelessly advocating for the role and the importance of consumer voice in health. So I would like to acknowledge that. And I'd also like to acknowledge everyone here today who has a lived experience of using our healthcare system, whether that is as a carer, as someone who's receiving services, or someone who's paying for services. You're also important. So let's see if I can get these things to go. Yes? Does it move along? Terrific. There's only a teeny tiny one here, so it's hard to tell, as you saw with Catherine before, if it's already moved. So see how we go. In the time I have today, I'll be covering a few themes, starting with what we know from consumers' general sentiments about Medicare, some of which are very similar to what Catherine discussed earlier, and then give you a little data from our consumer sentiment survey. We've done a couple of those. We're in the process of a third one, which will come out later this year, to hear what people think about Medicare and how the system works for them. And just before I start, for those that aren't familiar with the Consumers Health Forum, we're a national organisation that represents the interests of everyone involved in healthcare. So we don't use the word patient so much, not that we don't like the word, but rather we see the word health consumer as more encompassing. So you could be a patient, a client, a user of a service. You could be a carer. You could be someone who's paying for a service rather than receiving a service. In some way, you're consuming healthcare. So we think we're there to represent people from all those different perspectives. And we believe that healthcare in Australia should be accessible, it should be affordable, and it should be safe. CHF has member organisations. These generally peak organisations working in a variety of different areas of healthcare, as well as individual organisations. And we were really like the younger sibling of Medicare. We started around the same time, and we came into being as a consequence of the HIV/AIDS crisis, which really started people advocating strongly for different kinds of healthcare. And Australians got activated, and I'm regularly reminded of the parallel between that and now what's happened since COVID. Something happens, one of these tragic situations, and people suddenly get more interested in health than they ever were before. And Neil Blewett was also our original funder. So we would agree with the Health Minister this morning when he said he was our best Health Minister. Well, it's certainly very good for CHF, so we're happy with that. During the last 40 years, we've seen Australia change a lot. And as a consequence, we've seen the way that health consumers want to interact with the healthcare system change, not only as the users of the service, but increasingly as the designers of the service. We sometimes hear this word co-design used. I'm sure that you do a lot of that. We hear consumers saying they prefer the word co-deciding. They don't want to be there deciding if it should be pink or blue at the end of the process. They actually want to be at the beginning deciding what the problem is and what kinds of solutions might work for those. We see consumers wanting to be engaged in all things health, and we think this interest is not going away. We think it's only going to increase over time, and so it will challenge perhaps the paradigms of 30 or 40 years ago, where the patient would wait to be seen, and now, I mean, there's a great book if you haven't read it, which is The Patient Will See You Now. So in understanding actually what it is that patients want from the system rather than the system telling the patients what they can get. Of course, if organisations like ours aren't well funded, then that voice doesn't get through, and it's very important that this occurs. And we think that Australia needs a healthy, a robust, and I would say unapologetic consumer movement, which can take on the vested interests and also speak to government about what we all want from our healthcare system. So in terms of what consumers think about Medicare, I suppose we do need to reflect on, well, what do people think Medicare actually is? We had a terrific lunch yesterday to celebrate Medicare's birthday, including a birthday cake. So if you're not connected to us on our socials, do, and you'll see our Medicare birthday cake. And for a lot of consumers, they think Medicare is only bulk billing into their GP. That's what they think Medicare is. But of course, everyone here knows that Medicare funds lots of things, not only in general practice, and can be used to help provide access to all kinds of care, such as in the hospital, perhaps for your blood test and the like. So we would really like to see more people understand how Medicare works and what they can access through Medicare than can right now. And and as Catherine said earlier, you know, people really love Medicare. They really like the idea we have a universal healthcare system. We think, and the Minister commented on this earlier today, that it has been challenged over the last decade. And we know that Australians actually really value being able to access free care when and where they need it. They don't see it as a safety net. And we've heard that word in the media in the last couple of years, Medicare described as a safety net. So only accessing it if you can't afford otherwise. our information is in fact that people don't think it's a safety net. They think it's a universal healthcare system, and indeed many Australians think it's a right. So this is important, and I think it's overlooked too. So it's very important that people understand how Medicare works, not only in terms of what it funds, but what it does. So I was recently had the great opportunity to be overseas talking to other health consumer organisations and listening to them. So in the NHS, you're attached to a GP. So if you happen to go for holidays and you're somewhere else and that GP is not around, healthcare is a problem. Spoke to people from places like Spain and the USA who explained to me that their healthcare funding is linked to their municipality. So they're fine if they get sick at home, but if they're anywhere not inside their borders, they can't access care because the funding is held by their municipality. There are things like this, great things about Medicare that we're not sure that Australians understand and might make them love it even more and celebrate it even more. A couple of other issues that came through this recent meeting with the OECD around health were declining trust and, of course, the ubiquitous AI. I'm surprised no one's mentioned AI today. Everywhere I go, it seems to be the first thing that comes up. So what does declining trust mean for Medicare and for healthcare more broadly? From the level of someone believing what their GP or their nurse or the pharmacist tells them, or instead checking that ChatGPT agrees with it, through to people actually choosing alternative and perhaps not evidence methods for keeping themselves well because they have trust in their WhatsApp group or their Telegraph group much more than they do in government. And AI also a situation when we see some people love it and trust it. It's increasingly mediating our everyday actions, whether that's banking, shopping, whatever it is we do. Other people, of course, not. So it might be okay if you decide you just want to use cash and go to your local supermarket to buy things. But what does that mean if we digitise your healthcare? Does that mean you're now going to opt out of the healthcare system because you have low trust in either the veracity or the security or the privacy of digital solutions? So I think as we look to the future of Medicare, our policymakers, the governments alike, really need to keep these ideas front of mind. We also know that people understand that Medicare is a rebate system of some kind. And Nicole said earlier, you know, it's your rebate. I think some people think it's the doctor's rebate, but it's, you know, our rebate. But we don't know if people truly understand what that means and how they can best use their rebates. We've also talked to consumers about whether they would pay more, and actually many people would be happy to pay more tax if it meant that their medical services are more freely available to them all. So we've just seen a little bit of a change in terms of those rebates flowing through to people through the bulk billing incentives. And the Minister mentioned this morning, 360,000 more bulk billing, probably 300,000 from Cohealth and 60 from the rest of the country. But however many it was, it's really fantastic and consumers will want to see more and more of that. It's also important to remember that for many people, they've grown up with Medicare. They don't know any different, but not for everyone. And not only new arrivals, but there are other people who really don't understand the system. And so CCF's been really calling for the government to do a better job of explaining Medicare. In relation to our consumer sentiment survey, so we've run this a few times. I won't give you all the stats. There's a lot of information on our website about it. We did it in 2018 and again in 21. Some of the responses are different, and part of that will be COVID. A bit of COVID noise in there. The first survey we had just over 1,000 people respond. The second one, just around 5,000 people, most of whom in both cases had a Medicare card. And when we asked them, would they considering, you know, paying more for Medicare, about 40% said yes. And then about another 30% said maybe. So it didn't take much convincing to see that a lot of the Australian population really would even invest in Medicare themselves. And when someone will put their hand in their pocket, that's a real commitment, skin in the game. Not just I like it, but I would pay for it. I think that's really significant. We saw people's satisfaction increase over the period too, but whether or not that was because of COVID is difficult to understand. Their satisfaction both with primary care and with hospitals increased. And most people said, you know, just over most people, about 52% said the health system worked well. But 52% means 48% were not convinced. Now, we did ask a couple of consumers what they thought about Medicare. I'm going to try and play these videos. Everyone, fingers crossed. The first one from Deakin is a little bit soft, but I'm hoping the audio might get turned up a bit. Let's see if it will play.
Hi, my name's Justin Singh. I'm from Sydney and I've had Crohn's since 1991. I really like the Medicare system because it kept me alive during the 90s and really gave me the chance to thrive as an adult I am today. What I can see there is a big gap when it comes to the extra support needed when it comes to Medicare. Because Crohn's and there are other autoimmune diseases that are not really seen as visible diseases, we don't really get as much support as we much would like to have. So someone with a chronic illness that has an invisible illness has to fight a lot more and prove a lot more that they're sick, as opposed to someone who is, normally sick. So I find that there's a big gap. There's either the normal population that gets sick, and then there's the really extreme people who are, got very debilitating diseases. And I'd like to see the gap bridge in the middle for those invisible illnesses.
Great. We're also going to hear from Leonie. We think in retrospect, if we're doing Medicare again, we would have included the mouth. And Leonie talks a little bit about dental health. So let's see.
Hello, my name's Leonie, and I'd like to talk to you today about Medicare and oral health. So Medicare covers the whole body except for the mouth. And when I meet people, the one thing that they don't have access to is nearly always dental treatment. So they can go to hospital, they can see their GP, they can get subsidised drugs through the pharmaceutical benefit scheme. They can access some mental health services, psychology services and allied health through Medicare, but they can't access oral health care. So I want oral health as part of Medicare, especially for older Australians.
Yeah.
Thank you.
Yeah.
So 2 great presentations. And again, overseas talking to colleagues that work within the NHS. So in the NHS, dental is included. So if you see an NHS dentist, you can get free care. And they said the waits are between 2 and 7 years. So, and, I'm just thinking, Nicole, you would think about these things too. Service might be available and it might be free, but also literally you could be dead before you come to the top of the waiting list. And that's really not okay, especially in a country as fortunate as Australia. So in closing, really, what do we say for the future of Medicare? Well, we'd really like it to be strengthened in the way that the Strengthening Medicare Task Force is moving, particularly that the idea that fee-for-service primary care doesn't work for those who have significant health needs, whether that's chronic disease or other health disadvantage. We think Medicare needs to keep up with the changing needs of Australians. So our Medicare safety net and even our PBS safety net, having to carry around pieces of paper to record things, all those things, people don't do that anymore. The system really needs to, get up to date. We want to see Medicare support greater levels of healthcare integration. So we talked about pharmacists inside general practice. There are all kinds of other things where we can better integrate. As I said, with the benefit of hindsight, it should have included the mouth. Dental care Australia is not where it should be for a country like ours, and we really like to see an investment, noting it has to be large enough so that we don't create 7-year waiting lists here as well. So generally, consumers are incredibly supportive of Medicare. They've grown up with it. They love it. They don't know any other system, which also means they maybe don't know how good this system really is. We'd love to see the government invest in people better understanding it. And for those people who don't access it very much, but perhaps should, we'd love to see better ways of doing that. We do think the community might even be open to paying a bit more for Medicare, given how much they see it make a difference in their lives. And we know that it needs to better support people living with significant chronic disease. So thank you very much. I think you just need to use this. Thank you.
Yeah, so thank you for your attention. I think I'm sort of the last speaker, but before lunch. But in terms of acknowledging, certainly like to acknowledge the traditional custodians of the lands which we're all meeting from. Here today in Nam is the Wurundjeri and Bunurong people of the East Kulin Nation. And I'd like to acknowledge any Aboriginal and Torres Strait Islanders that may be elders past, present, those who may be in our meeting today. Really good segue, and thank you, Karen, for the opportunity to provide the perspectives of oral health. And Liz has mentioned I've worked with Consumers Health Forum for some time now, and continue to advocate that. Perhaps thinking, is Medicare really, from my perspective, is it really truly universal when it doesn't really include oral health in the system? Just to highlight a couple of things, and I guess it's not probably not an issue most may not be familiar with, but certainly a good reflection of why oral health is important. We know that hospitalizations due to dental conditions is quite high, particularly for young children, and still persistent at this point in time, and it's remained relatively steady over the years when we're thinking about the indicators around preventable hospital admissions due to dental conditions. There are other diseases beyond just diseases that is quite common in children in terms of tooth decay. So there's other burdens of disease which is quite prevalent in the Australian population, but often can be probably not have an appreciation about the complexity around oral diseases regarding the gum health. And there is growing evidence now where we're finding, whether it's causal, whether it's, due to the common risk factors that are associated with severe gum disease and other systemic health issues. And of course, the severity of oral diseases, as it progresses, it becomes chronic, acute pain can lead to severe tooth loss. And of course, that can affect things like smiling, oral function, and so forth, health and well-being. This is a slide in around, and it's actually an interactive slide, so you can actually find this through the FDI organization. That's the Peak Dental Dentist Professional Association internationally. They've got a good image here, and it's an interactive map that links the issues around oral diseases and systemic health. That they've sort of presented as whole body health, but for me, I feel like that it's sort of missing that holistic health as well. So thinking about oral health is more than just physical health, but it's all about health and well-being, and also health and well-being often is typically across not only within individuals but within families and communities through that sort of social determinants, that commercial determinants perspective as well. We know oral disease prevention, certainly prevention is something that as a dental practitioner, I'm a oral health therapist and a practitioner that many of you may not be familiar with that term. But there are ways in which we can prevent oral disease. Things around water fluoridation is a grand example of one of the most important public health achievements that we've had in Australia. Still a bit of work to do in that space. Things around fluoridated toothpaste certainly has made an impact from a personal care perspective. Some other probably not well-known public health interventions that is very useful for to prevent oral disease. So things like fluoride varnish. So it's basically a medicalized form of fluoride that is applied to teeth to help prevent tooth decay. And also there's things around policy as well. So thinking about a health levy in terms of sugar-sweetened beverages. So that's one of and there's actually now strong evidence now in terms of that type of policy reducing tooth decay in other countries that implemented it. I've touched on mostly tooth decay because that's where a lot of the public health, dental public health initiatives have happened, but we really haven't touched on the other important aspects of oral disease is really around gum disease as well as severe tooth loss, which I think probably has a greater burden, oral disease burden for individuals and society. Talking about workforce, so thinking about it's not just the dentist that provides oral health care. So like myself, I'm an oral health therapist. I work in community health right now. I work at your community health. I'm collaborating with a number of colleagues with Cohealth, and it's good to see Nicole here. I also have another hat on, so I do work for Dental Health Services Victoria. So thinking about transformational change and how we can work from moving away from sort of fee-for-service type models and thinking about how we can actually link activity with outcomes. And I think that's where we need to move in terms of Medicare reforms as well. Obviously, early childhood is something we want to focus on. And then the other aspect of it is, health workforce is also about other models of care to support oral health as well. So thinking about, GP practices to support oral health, nurses and midwives, looking at the, in terms of that maternity health space as well, pharmacists, speech pathologists, occupational therapists, they all work in their areas of health. And often, and I think it's because of this separation from oral health, that's there's a strong history around that, particularly from the US, why that's happened. But thinking about how we can actually embed oral health promotion within the core curricula of the other health professions to help lift the issues and the responsibility of how oral health has an important role to play in health and well-being overall. From a international context, policy context, so there are, I guess, various understanding of what universal oral healthcare looks like, and we know that not all dental services would be considered essential. There's a bit of work now undertaken by the World Health Organization that's thinking about this definition of what is essential, and I think that's something that our government and all stakeholders need to think about. What should really be funding? Think about essential oral health care, and also not necessarily funding things that may not necessarily be conducive to health. So, for example, there's this I guess socialized perspective that we need to see the dentist every 6 months, and the evidence tells us that that's not the case. In fact, it's there's actually no strong evidence for that. And so thinking about and trying to de-socialize things that are so embedded in our society in terms of what is effective policy to help to not only make sure that we are allocating resources in the right way, but the most efficient way as well, and to achieve outcomes that we want. We've had a dental inquiry last year. So a dental inquiry that was, I guess, advocated by the Greens. The Greens have always been a strong advocate of a universal type dental care policy. But again, it's thinking about the nuance around what is essential from my perspective, and from others here in the room as well has similar opinions, that really we should be thinking about funding what is fundamentally essential for oral health, and also what is clinically relevant as well and clinically necessary. Some of the key recommendations that I think would be pivotal to drive this area of reform, to think about how we can get oral health in Medicare, is thinking and highlighted through this inquiry is this an office of a dental oral health within government. Thinking about how we could achieve universal access is through this concept around essential oral health care. It's still loosely defined because at the moment our funding current mechanisms is fee for service. It's based on a schedule of fees. It's really, I guess, input driven and not necessarily output driven in terms of outcomes. And so it's thinking more deeply around what works in other areas, like, for example, the MBS. I think there's strong descriptions around those type of services, but the type of dental services that we do deliver right now has not had that scrutiny at this present time. And certainly dental services that is currently funded hasn't gone through what we call a health technology assessment either. So that's things, health technology assessment happens through the MBS, so the Medicare benefit schedule, and the PBS as well. And then finally, and it just touches on the importance around embedding oral health opportunities. So thinking about embedding oral health assessments within MBS items, and maybe thinking about rejigging reimbursement rates for that to help cover that aspect of helping to support other health professionals to be trained to develop competencies in oral health promotion. And then there's things area of assessment, like I mentioned, things around pharmacy, things around residential aged care as well. So I guess what's next, and just some reflections. I mean, for us, we're from a expert perspective thinking about what is essential and help to and working with a number of our consumers as well to sort of test the idea of what is considered essential. That's the first step. And then thinking about how we can link not just service delivery, but service delivery that actually is matched or tied to outcomes. And then, you know, we've talked about workforce as well today. I think, you know, what is the regulatory levers as well in terms of how we can support the non-dental health workforce to support oral health promotion. Of course, it's always good to have good data surveillance, particularly in the oral health space, because the area of oral health research is quite minimal in this country at this point. And with my health economics hat on, with Deakin Health Economics, you know, we really need to use economic evaluation or health economic assessment, thinking about the health economics aspects of good policy around oral health as well. And then I'll leave that there. Thank you.
Okay, so if yes, three speakers could just gather here, thank you. And all really interesting presentations touching on a range of issues that some of which have already been discussed, some of which are new. I mean, as Elizabeth said, artificial intelligence hasn't been mentioned yet this morning, I think until she did. We haven't got a great deal of time, so there, as I said, there are a number of things that we can pick up on, but this group seems to be pretty keen to ask questions. So I think I might, if people have got questions, let's go to them. And if you are feeling shy or hungry, then we'll have some panel discussion. But otherwise, I think we should open it up to some questions from people for each of our panelists. Anyone want to kick off? Please.
Dr. Tan, you mentioned that the 6-month checkup thing, which was news to me, isn't you know, scientifically backed or rigorous or whatnot. Using that frame around essential services, do you have a sense of what is the appropriate amount of time between checkups?
Yeah, it's a really challenging space. And I guess sometimes it goes back to expert opinion, but ultimately it's sort of a risk-based approach right now. And we know that logically makes sense because not everyone has the same disease burden. Some people are healthier than others. So the risk-based approach is probably the logical approach. In terms of the context of essential, I think that would be challenging to sort of address that risk-based approach because we know sort of a universal testing is to be made available for everyone, but maybe there are people with high needs that need regular checks, for example. In my mind, I think there's a role for the state and territory governments to play there. So as like, I guess, the state and territories have their own dental programs. And so I think they have a role to address sort of that, those niches in terms of addressing the high needs. And then in terms of the federal level is looking at that universal level. And then you've got the layer of the state and territory governments to think about how can we actually reach those populations that aren't accessing it or are having those high needs that isn't addressed through a universal type scheme.
It's a really good example, and I can say this too because I'm a dental practitioner and there's no one from the ADA in the room. But it's a really good example of where fee for service drives the business model. Yeah. So we're not providing 6 monthly checkups because it's good for your health. It's about business model. And that's where I go back to Moss Cass's vision, you know, healthcare is not, it should not be a commodity. It's a right.
So is that also partly driven by, if you like, health economics, as you were referring to earlier, in the sense that you're trying to work out, okay, there's universal idea, as in what the average Australian, so to speak, might need, and then there's the sheer economics of it, which, I mean, we all know that there are economic issues underpinning the provision of Medicare. So if you just said everyone gets it and every 6 months you should go and get your checkup, that would probably, I imagine, blow up the system. So is that part of it as well?
Yeah, absolutely. And
and we're working with colleagues across Dental Health Services Victoria and other colleagues from other universities thinking about, what is that minimum requirement. In my mind, I mean, I'm much more optimistic. So I mean, I would be comfortable with a checkup every 2 years, every 3 years perhaps. Personally, I haven't seen someone for probably 3 years right now. Probably not, not for optics, but it's purely because I don't have that need.
Yeah.
I'm not in that high risk category.
But you also know, I presume,
Of
when
course,
you see it.
yeah.
Some others
That's
don't.
absolutely true. But that minimum requirement, I think, it's 1 year or 2 years is probably reasonable. That also frees us resources. So if someone's seeking care every 6 months when they don't need it, then you're freeing resources for those higher needs group to access care. Then they wouldn't have that opportunity.
Yeah, 20% of the population has 80% of the oral disease burden.
Yeah.
So I know why we're all going.
Yeah. Really good point. The MOSCAS thing in particular. Yes, question.
Jim Gillespie from Sydney University. The question to Liz, I saw your presentation at the OECD, and you made a tantalizing reference to Amazon and sort of new approaches of people consuming health. Can you explain what you're getting at there?
Sure. So I should point out, I'm not a big fan of Elon Musk, just in case anyone's thinking that wasn't probably evident. So a bit what I suppose what I said before, the way that people interact with services has changed. And so now people expect they can go to a website, push a button, and something gets delivered. So that, if you like that, you can call it the gig economy, AI, Amazon, all those notions. But what happens is that you might have that experience in banking or retail or education, for example, also, but then you hit health, and it's 1950 maybe, not even 1980. So 80% of all the faxes used across the entire planet is health. Okay, so if you think in your daily, I can't believe you have a fax number if you're not working medically, right? No one. In fact, young people don't even know what a fax is. So what we're seeing is this dissonance between people's everyday experience and then health. And when they butt up against health, they're often really surprised that that's how it works. And that's what we saw a lot of during COVID, that people who hadn't had to access healthcare, who suddenly did, went, it works like what? In fact, it's not unusual when someone first has a new disease or diagnosis of cancer and they have to interact with health perhaps intensively. Their response is, I can't believe it works like this, in its clunkiness. Not talking about the quality of care, but in its clunkiness. And so the expectations increasingly of people in the Western democracies, particularly, I think, is that they should be able to press a button. Why can't I press a button and speak to someone who triages me? We talk about burden. I've got this problem, great. And then here are your solutions. Why can't a drone come and pick up results from you? I know, scary. Why can't an AI give you some advice when what you need is actually very low level support? Why can't you get a bot that gives you interactive self-care advice? All these things we can get everywhere else. And so I think the challenge for governments really, and I suppose for policymakers too, is how do we keep up with societal change or even disrupt and move past it? Because traditionally our government funded systems are very slow and mysterious in the way they work. And the Westminster system of government kind of causes that. I'm not suggesting we shouldn't have it, but I just think that it needs some tweaking. And I think that's really what I was referring to, that dissonance between people's daily life and their experience of healthcare. And what can healthcare do to be more like everything else, where that makes sense.
Sorry, where does Elon Musk come into this?
Oh, just because I said it was like they want the Amazon experience of healthcare. People thought I meant they should click and get a book or something, but it's more that experience of the digitally mediated service provision, which we see in bits in healthcare. And I think the other bit about healthcare, of course, is it's the way we navigate it. Because of the many funding streams, I mean, you've got 85, but there are actually hundreds. And so for individuals to work out which service they can get and how, super challenging. And again, if you go back to that idea of going to one place, We hear that with private health insurance too. People saying, before a private procedure, I want one quote and one bill. I don't want to ring 5 places and try to work out what my out-of-pockets will be. But this is what people increasingly want.
We've just about hit time, and I'm going to, you mentioned Elon Musk has reminded me of, I don't know if you know, but when he was having some dietary problems recently, he saw a photograph of himself in a bathing suit, which didn't find attractive, and so he decided to go and diet by using Ozempic, of course, as you do, because that's what it's diet is drug du jour. And his idea was A, to do that, and B, not. Then he went on to the fasting diet and decided not to eat anything until midday. But at midday, what he lined up was cheeseburger, double Mac, you know, a kind of a couple of smoothies, just some ghastly series. So anyway, I didn't think Elon Musk would be mentioned, but I couldn't resist. So thank you. Can you please join me in thanking our